Welcome to the fourth class of M174. Today we're going to be talking about the newborn and postpartum care. So we're starting out with the newborn first. Let's do the newborn assessment. The newborn has to do several changes physiologically to adjust to extrauterine life. So what happens is that right before the delivery, all of the oxygen and nutritional needs of the fetus are being taken place by the placenta. The lungs are not functioning, and they are actually filled with fluid. And the fluid helps to keep the alveoli open. As the baby progresses during the gestation, the amount of lecithin and sphygmomyelin increases to the ratio of about 2 to 1. And the LS ratio has to be 2 to 1 in order for the lungs to be mature and to support the respiratory system. And that occurs somewhere around 32 to 35 weeks of gestation. So what makes them take the first breath? Well, there's 4 different factors. One is thermal. They're leaving this very nice, warm, comfortable environment out into this cold delivery room. There are mechanical factors, the biggest one being that the baby comes through the birth canal, the lungs are compressed and then expanded again. That helps the alveoli to open and helps to get rid of some of the fluid that is in the lungs. There are chemical receptors in the carotids and the aortas that pick up the amount of oxygen and CO2. And then, of course, there are the sensory things. There's the lights, there's the voices, there's the touching by the hands, being on a hard surface. All those things irritate the baby, bother the baby, and make the baby cry and take that first breath. And it's the crying that actually helps the lungs to clear. So respiratory-wise, at birth, the newborn has a respiratory rate close to around 60, and during the baby's time there for that first month, the respiratory rate's about 30 to 60. Babies only breathe through their nose. They don't open their mouth to breathe. And also they have diaphragmatic breathing, meaning that when they breathe, you can actually see the abdomen going up, and the respirations that they take are shallow and irregular. They have the circumferential cyanosis, and if you look at this baby on the left lower part of the slide, you'll see that it has a bluish tinge right above the upper lip. If you were to open this baby's mouth, it would be pink. So that's not all that uncommon to see, probably within the first hour of life. And then, of course, they have the acrocyanosis. This baby has it just in the hands and the feet, but sometimes it can go up the arm and up the leg a little bit. Okay, babies have something that's called periodic breathing, and that's what makes them have the irregular respiratory rate. They have periods of apnea that last about 5 to 10 seconds, and there is no color change or change in heart rate. Now that's different than apnea, which is when they have no breathing for periods of greater than 15 seconds. That should be evaluated. You're going to see that primarily in the premature infant. And then there's transient tachypnea of the newborn, and that's where you have an increased respiratory rate, and it's due to the poor absorption of fluid from the lungs. A baby might have a little bit of grunting with that, maybe a little bit of substernal retractions as it's trying to make that adjustment. Usually what will happen is if there's enough staff on hand, the nurses will watch that and do some percussion and some other things that we're going to talk about in a minute to try and help get rid of all that fluid in the lungs. But even if the nurse doesn't have time and the baby has to go to the nursery or to the NICU, these babies usually do quite well. So when the baby's first born, their lungs are wet. They're all wet. all right? But if you were to listen in 5 minutes or 10 minutes after the birth, you would be amazed at how clear the lungs get. Okay, we all know about acrocyanosis, but some babies have something called mottling, where the skin has this spider web appearance to it. This can be due to the fact that the baby's cold, but you also just see it more in very small, thin-skinned babies. Opposite of that is a ruddy color to the skin, which is sort of a reddish, very deep red color, and that's due to polycythemia. So to help the baby transition, you're going to suction. The majority of the time, all you need is a bulb syringe. Keep them in a side-lying position. You might put the head down. You're going to use a little pink and blue percussion hammer. If they're not clearing the fluid and they're more symptomatic, you might give them some oxygen as well, if that's the case. And you're just going to keep assessing the lung sounds periodically until they are clear. Normally, you're going to count the respiratory rate and do all the vital signs every 30 minutes times 4. And then lots of times babies' lungs do not sound perfectly clear, but they are not symptomatic except for maybe a little bit of increase in respiratory rate. Lots of times if you put them skin to skin and give them a little time, their lungs will improve. Okay, so you know from peds all about the cardiovascular adaptations that the ductus arteriosus, foramen ovale, and ductus venosus need to close. Those are all important to divert blood from the lungs and from the livers in utero. But then once the baby's born, their own lung and their own liver need to take over. This is the process by which that occurs. So you guys could read more about that. So we all know about acrocyanosis. That's normal. I talked about the circumoral and the mottling. These are all things that sort of tell you that the peripheral circulation is not complete and intact all the way to the periphery. Okay, so let's look at the baby's temperature. Normally you want it to be above 98 degrees. The pulse is between 120 and 160. You're going to notice that it goes down to the lower limits when it's sleeping and increases when it's crying. Let's say that the baby's heart rate is 172. I would record that and then I would put crying next to it. Or let's say that the heart rate is 115 and the baby's sleeping. I would put sleeping by that. But the rhythm of the heart should be regular. All pulses, and here I'm talking about brachial and femoral pulses, should be present. It is more difficult to detect the femoral pulses. Respirations are between 30 and 60. Some books will say 40 and 60. And typically we do not measure blood pressure in the hospital, or if we do, we maybe just check it once. We check capillary refill. I usually do it over the sternum because if you do it over the hands and feet, well, that's not going to be very good because the baby has acrocyanosis. All right, so this link here, I would encourage you on the other PowerPoints on the blackboard to click on this link and listen to the heart sounds, and especially work on counting the heart sounds. So within the first 2 hours of life, usually after the golden hour, these measurements are taken, and these are your averages. Okay, so probably the biggest discrepancy you're going to see is the weight, because the head and the height are, those parameters are more common. And these are just examples of how to take the measurements, and you should know how to do that from peds. All right, let's look at weight loss. So In the first few days of life, it's normal for the infant to lose 5 to 10% of the body weight. If more than 10% is lost, then you're going to evaluate that baby and especially look at how often they're feeding, um, that type of thing. Their weight should be regained in the first 1 to 2 weeks. So at the 2-week checkup, they should weigh what they weighed at birth or more. And then their weight doubles by 6 months and triples by 1 year. All right, we have gone over this in the skills lab, the APGAR sign. And what I want to sort of maybe draw your attention to is that in trying to calculate the APGAR score, I think that it's easier to give the baby a score of 10 and then subtract things from it. For instance, the other day in clinical, we had a baby who was born and the baby had no tone, and the color was blue. All right, so that baby had, and the baby also had acrocyanosis. So we started out with a score of 10, and then we took 2 off for muscle tone, so that brings it down to an 8. And then we took 1 off for color, so that brings it down to a 7. And then the baby was only minimally responding to us, so we took 1 off for reflex irritability. Okay, so did you see how I did that? We took 2, 1, and 1, so that baby had a 1-minute APGAR at 6. At the 5-minute APGAR, the baby was much better, and the only thing that we took off was 1 for acrocyanosis. So that baby's APGAR score was 6.9. Okay, these are all babies at birth, and they all are pretty blue. This is probably immediately after birth. Okay, one thing that you've probably noticed already is that the baby's head looks significantly different at the time of birth than it does even a few hours later. And that's because as the baby comes through the birth canal, the bones in the skull shift to accommodate that. And they do that because the skull is not all one big solid bone. They are several bones connected by sutures and fontanelles. So when the baby's going through the narrow pelvis, the bones overlap on the scalp. You could sort of see it here down in this on the lower left-hand side there. But when you look at this baby has a little bit of molding going on, and in the right picture you could see the overlapping of the sutures very easily. Sometimes you could only feel it and not see it with the naked eye. Oh, okay, so caput succedaneum, we usually just call this caput, is when there is a collection of fluid underneath the scalp that crosses the suture lines. Okay, and another very common characteristic of caput is that it has this pitting edema, which you can see in this one picture. So the two things about caput is that it crosses the suture line and that you are able to indent it. Okay, now this picture sort of shows you that caput is centrally located, and many times that's true, but not always. Okay, so now this slide is showing you the difference between caput, which is the one on top, where there is edema right underneath the scalp, and a cephalohematoma on the bottom, which is a collection of blood, not just fluid, in between the skull bone and the periosteum. Okay, so you can see just looking at these two that the caput covers a wider area on the scalp, and it goes beyond the sagittal suture. These are just some examples of what caput looks like. Also, I'm sorry, what cephalohematoma looks like. I also think that it also has a bruise-like appearance to it. It may not always be very apparent at delivery, and sometimes caput looks like a cephalohematoma, but then later on you realize it was just caput. Okay, so why is it important that you differentiate the two? Well, one of the main reasons is because caput will resolve within 24 hours, and a cephalohematoma is going to take probably weeks to resolve. So you would want to do that patient teaching. And with the cephalohematoma, there's probably been some trauma involved. And so then you're going to look for other symptoms that trauma took place. And we'll talk about those in a little bit. And those babies, because, the injury has occurred there, they might be a little bit more irritable and act like they're in pain. Okay, now on to the thermoregulation, which we're including under the neurologic adaptation here. It's really important to keep the environment in a neutral thermal temperature. Um, the room needs to be about 10 degrees warmer than an adult would like it. And what I tell parents is, if you and the baby are in the same room, put one extra layer of clothing on top of the baby, or one blanket, okay? This is because, the babies have less subcutaneous fat, their blood vessels are closer to the surface, they have a much larger body surface area, and so they can lose their heat much faster. And in a very mature baby, they're well flexed, which helps to keep the heat in, but in a preemie, they don't have that flexion and they're more likely to lose their heat. So how do we lose heat loss? How do we lose heat? Well, it's very important for the nurse to understand all these, because one of the big responsibilities of the nurse is to prevent the baby from getting cold. And if you don't know how babies get cold, then how can you prevent it? So these are the 4 ways. Convection, that's when the body loses heat to cold air. So like if you have a window open, if you have air condition blowing over the baby. Radiation is when the baby loses heat to an object that is close to them but is not touching them. So if you have the newborn crib next to a cold window, if you have the crib next to a cold table, the baby can lose heat that way. Probably one big way at birth especially is through evaporation. So the baby's all wet and amniotic fluid and blood, and what do? We dry because we know that the baby's going to lose a lot of heat, so through evaporation. And then lastly, through conduction, where the baby loses heat when it is in direct contact with an object that is much colder. So, that's why we heat the radiant warmer up before we place the baby on there. That's why we put a towel on top of the scale, the cold scale, to prevent some of that loss. So very important, that we really pay attention to all these things. Let me backtrack here a little bit for the evaporation. When you're giving the baby bath, it's really important that you do it fast, because they are losing heat just by being exposed to the air and then losing heat through evaporation. Okay, so if you and I were cold, what we would do to get warm is, first of all, we go get a sweater, right? And then we put our arms around our chest and maybe rub our arms. And we might start shivering and we'd get goosebumps, and all those things would help us to get warmed up. But babies can't do all that. They don't shiver. And the way that they produce heat is through burning brown fat. So brown fat is stored in the baby's body at the nape of the neck, at the axilla, around the kidneys, and around the mediastinum. And if the baby gets cold, it breaks down this type of fat and it produces energy to heat up the baby, but it also releases fatty acids. And the fatty acids can be implicated in metabolic acidosis. So when the baby is trying to generate this heat, the metabolic rate goes up. When the metabolic rate goes up, the oxygen demands are increased. So one thing that happens to babies who are cold stressed is they will go into respiratory distress. So any baby who's cold, I'm really paying attention to, how fast they're breathing. Are they starting to grunt? Things like that. My antenna is up for that. So some things that you could do to prevent cold stress. Well, first of all, be aware of all those 4 ways that you lose heat. Take the temperature within 15 minutes after birth. Make sure you've got a warm baby to start out with. Dry that baby. You're going to have to change that blanket several times until they are wrapped up in a warm, dry blanket. Make sure the radiant warmer is turned on. You're not going to bathe that baby until their temperature is stable, and you're going to check the temperature right before you give the bath. You might, if the baby becomes jittery or shows any other signs of hypoglycemia, you might want to check the blood sugar because you've been using up the baby's blood sugar in trying to increase the temperature. And you're also going to be watching for the respiratory system. So if a baby's cold, what you're going to do is it's going to depend on how cold the baby is. So let's say that they're 97.6. Well, then I would probably put a cap on the baby and put the baby skin to skin with mom and put a warm baby blanket and a warm bath blanket on the mother and recheck the temperature in a half hour. Now, if the baby were 96.8, I would be a little bit more concerned. They're going to develop respiratory distress. They're going to develop hypoglycemia. So then I would probably put them under the radiant warmer, connect them to the probe, and watch them a little bit more carefully. I think I talked about the respiratory distress and also the hypoglycemia, but I want to talk a little bit also about how these babies are also prone to jaundice because with the release of fatty acids into the bloodstream to try as a byproduct of burning up the brown fat, those fatty acids can interfere with the transport of bilirubin to the liver to become conjugated. So what causes jaundice is unconjugated bilirubin. And so these babies, not right away, but maybe hours down the line, might develop jaundice. Okay, so then you have to worry about all the problems associated with hyperbilirubinemia, which we'll talk to in a little bit. Okay, let's go on to the neurologic system. All the neurons are present at birth, but many of them are immature. That's why their movements are uncoordinated. There's really no muscle control. There's no fine motor at all. Sometimes they'll be really sort of tremulous, and it might be a little bit difficult to differentiate that from jitteriness. And then of course you've got the Moro reflex, and you have all those other reflexes as well. So most babies, are born neurologically intact unless they're premature or they have kernicterus, or they develop hypoxia and have subsequent brain damage. Sometimes babies will have a traumatic birth and their motor reflex won't be very strong, or it might be difficult to elicit, but as the baby recovers over the next hour or so, usually the motor reflex improves. Okay, this is looking at the hematological adaptation. The white blood cell count goes up at birth. You can see the red blood cell and hematocrit and hemoglobin count here. If a baby has, let's say a 74 hematocrit, well, you have to worry about all the breakdown of those red blood cells and how that contributes to jaundice. Because their GI tract is not mature and it can't produce the vitamin K, they are at risk for clotting deficiencies and at risk for bleeding, and that's why we give them the vitamin K at birth. And they do have about 3 months worth of iron stores, thanks to mom on board. Okay, we're going to take a little bit more in-depth look at hypoglycemia at birth. You want the blood sugar to be somewhere between 40 and 70. And there might be indications for you to think that the baby is hypoglycemic, like we've already talked about with the hypothermia. And the signs and symptoms of hypoglycemia that you're going to look for is jitteriness, poor muscle tone, tachypnea, dyspnea, apnea, cyanosis, temperature instability, not sucking very well, a high-pitched cry, being somewhat lethargic, and probably worst case scenario, having seizures. So where do you stick the infant? Well, obviously we don't do it on the tiny little fingers, and you want to avoid the nerves and the arteries, so that's why we always do it on the side, on either side of the heel. All right, these newborn reflexes, I think you guys know this pretty well. This is part of your preclinical workups. I'm not going to review this. This examples. Okay, the GI system is pretty immature at birth. It reaches maturity about 2 or 3 years of age, and when the baby eats, it easily becomes distended after eating. And you have to realize that at birth, the stomach capacity is only about 5 to 7 milliliters. So that's like a teaspoon and a half. And that's important information to share with the parents, because they might think, oh, my baby, we gave them a little supplement and the baby only took 10 milliliters. That's not even an ounce, and you just really need to educate patients on the size of the baby's stomach. So, you want to get that nipple at the back of the tongue so that they can suck better. Sucking usually starts at around 32 weeks. That's why the preemies who are born prior to 32 weeks, or even at 34 weeks, they really don't have a very good coordinated suck, and they also tire out easily. So that's why they frequently need to be fed via NG tube. Saliva doesn't start developing until about 3 months of age. That's when you see all the drooling going on. And bowel sounds are definitely heard by 1 hour of birth. Usually, I can usually hear them at birth. Okay. Newborns have difficulty digesting complex starches and fat because they lack the lipase and amylase. And so that's, why we don't start introducing solids until 6 months of age as their GI system starts to mature. That's why we don't give them cow's milk because of their difficulty with digesting things like that. So we all know that the baby's initial bowel movement is called meconium. We're going to review that in just a second. And the gut is sterile at birth. And it takes a while for normal flora of the GI system to get introduced, and at that time, vitamin K can be synthesized. Oh, isn't she cute? Okay, so here's all the different types of poop. We start out with meconium, which to me looks like pudding, chocolate pudding that's been left in the refrigerator a little bit too long. That progresses to a transitional stool, which is like a dark green, almost seedy in appearance, and then turns into a yellow stool. Now, I think your book says that that takes a fair amount of time, but it really just depends on, how frequent is the baby eating? How many bowel movements are they having? So, I mean, a baby could be down to the transitional stool, by day 1.5. The nice thing about breastfeeding is that the stools do remain that yellow and they're not stinky either. So that's a plus for breastfeeding. Okay, the liver, the ability to metabolize drugs is not very good because the liver is not fully developed. And so one of the things that we really worry about with the liver is its ability to conjugate bilirubin. To take unconjugated, which is also called indirect bilirubin, and turn it into conjugated or direct. So the main source of bilirubin is the breakdown of red blood cells. And red blood cells are broken down because of the baby has a cephalohematoma, especially a big one. In order for that to get absorbed, it has to break down, and the byproduct of the breaking down of the red blood cells is the release of bilirubin. Also, if a baby is polycythemic, the same thing occurs there. If the baby isn't taking in enough food, then that decreases the flora in the GI tract, and since the majority of the bilirubin, even the conjugated bilirubin, is taken out through the stool, it doesn't get eliminated. Okay, and we also talked about how asphyxia and how that could cause the release of fatty acids with the burning of the brown fat. So there's lots of different things that might make that bilirubin go up. Another group of infants who are at risk for hyperbilirubinemia are premature infants, and that's because their livers are even more immature. So almost every baby in the NICU ends up under the Billy lights. What we're trying to prevent is kernicterus, and that's where the bilirubin crosses the blood-brain barrier and actually infiltrates the brain tissue, and that results in usually severe brain damage. Okay. Oh, I forgot to mention that another cause of hyperbilirubinemia is when you have an ABO or an RH incompatibility, because you're having the breakdown of the red blood cells. Okay, so this is just a picture of a jaundiced baby. All right, so these are your normal bilirubin levels. And what I want you to walk away with here is that it's really important to know how old the baby is. Because if the baby, let's say the baby is 50 hours old and has a bilirubin level of, let's say, 10, we're not too worried about that. However, if the baby is a newborn and is jaundiced and we do a Billy level and it's 10, we are going to be very concerned about it. So it's really important to know how old the baby is. there's something called physiologic versus pathologic jaundice. Um, Physiologic jaundice occurs because of the liver's immaturity and the fact that even without a cephalohematoma, red blood cells are being broken down. So this physiologic, or I want to call it good, type of jaundice occurs after 24 hours of life, and the Billy level is around 5 to 7. Whereas pathologic occurs within the first 24 hours of life and may go as high as 12 in a full-term infant. Okay, so the takeaway here is that jaundice within the first 24 hours is pathological. There's also something called breastfeeding jaundice. And breastfeeding jaundice is categorized into early and late. So early onset breast milk jaundice is usually due to insufficient intake. You know, the baby's too sleepy or isn't nursing very frequently or is too tired to nurse or is just a poor sucker and they're not supplementing enough. So to treat that, you want to, help the woman with breastfeeding and supplement with express breast milk or with formula. Late onset breast milk occurs around the 3rd to the 5th day of life, and what we usually do for that is we usually take them off the breast milk, let the mother continue to pump, and to feed the baby formula. And it's thought that there's something in the breast milk that is causing the jaundice. And so we just take them off of it temporarily, like for 2 days or so, and then we put them back on it. Meanwhile, we put them under phototherapy and treat them that way. And then after the 2 days, they go back on breast milk, and lots of times the bilirubin level will go up slightly, but not as much, and then they should be okay to breastfeed. The important thing is that the mother has to continue to pump on a regular 2 to 3 hour basis during that time in order to maintain milk supply. Okay, so how do we assess jaundice? Well, I usually start looking at the head and I'll press on the nose or on any bony area on the upper chest. And as the hyperbilirubinemia gets worse, the jaundice color is going to move from the head down to the chest, down to the abdomen, upper abdomen, and then lower abdomen. So you could sort of look at the baby and sort of know, oh well, God, this Billy level must be really high because it's all the way down past the umbilicus. Also look in the eyes and check the urine. The urine tends to be very dark as it's trying to, get rid of the bilirubin. These babies are frequently very sort of lethargic and irritable, and they don't want to eat. Sometimes they're vomiting. Sometimes they have, decreased moral reflex and sucking reflex and rooting. And they're not really happy. And then what do? We put them under the lights, and they're even more unhappy. Okay, we're going to be talking more about hyperbilirubinemia in the classroom. All right, let's switch over to birthmarks. This is a picture of a hemangioma. They're also called stork bites, and what they are dilated capillaries. And when you press on them, they blanch with pressure. And you see them on the base of the neck like that, or on the eyelids or in the middle of the forehead. And like I said, they blanch. They might get darker in color when the baby cries. And what you want to tell the parents, especially if they're very obvious or in a bad location, is that they usually disappear by 2 2 years of life. In contrast with the nevus flammis, it's also called the port wine stain, when you look at this, it has a deeper red color. The demarcations of it are more abrupt and clear. It does not blanch with pressure, and this is a permanent birthmark. It can be taken off and removed with a laser. This is a nevus vasculosus. It's also called a strawberry hemangioma. This is a raised one, and this is a flat strawberry hemangioma. It's also called a nevus vasculosus. Now this is a picture of a strawberry hemangioma and how it looks over time. So you can see it between this baby's eyes, and they might be, dark and raised and rough looking, and then they might grow in size for a few months and then disappear and be gone by school age. So at the bottom of this frame, it shows you how it gradually disappears. And that's what you want to tell the parents. We don't usually do anything for these. These are cafe au lait spots, and these are permanent light brown areas, and if they're less than a half a centimeter in size and there's less than 6 of them, we don't worry too much about them, but if they're larger or greater in number, then we think there might be some type of underlying genetic neural tissue problem and would need subsequent workup. Okay, these are Mongolian spots. We tend to think of them only on the coccyx area, but you could see this baby has it on the abdomen. Sometimes they'll go up the back. I've seen them on the legs. I've seen them on the arms. And it's really important that we document these at birth so that they aren't mistaken for bruises subsequent to child abuse later on. Okay, this is erythema toxicum, also called little flea bites. These are red blotchy areas with white papules. You'll see them usually within 24 to 48 hours, and they're on the back and the shoulder and the chest. And they usually go away within 10 to 14 days. This is milia. These are tiny little white papules due to plugged sebaceous gland, and you typically see them over the bridge of the nose, under the nose, and above the lip, sometimes onto the cheeks and on the chin. And these usually disappear within 2 months without any treatment. Miliaria are these little red papules, and they're due to closed sweat glands, and they're usually because the baby's too warm. Even older children can get these when they're overheated. It's not real clear, but this is petechiae, and sometimes in a delivery, especially where there is a rapid onset of a pressure followed by an immediate release of pressure, like if a woman's pushing and then stops pushing and then the baby's body is trapped somehow, it causes these little flat pinpoint hemorrhages underneath the skin, and those will go away. They'll be absorbed. You also see this on mom's face sometimes from pushing, and when she's pushing in her face and not pushing correctly. Okay, so during a delivery, you want to be aware of, if you're let's say the nursery nurse, what type of delivery this baby had. If the baby had a forceps or a vacuum extraction, well, then we have to worry about trauma in some way. Also, have a severe caput or cephalohematoma from the vacuum. Okay. We're always interested in the baby's ability to pee. They should void within the first 24 hours. It could be clear yellow. It might be a little pink bricky color. The female babies might have a pseudomenstruation coming from the vagina, and that's due to the hormones of the mother. Okay, the newborn's immune system is immature. That's why you want to teach parents to avoid crowds, that when family come to visit the baby, they should wash their hands. Anybody who's sick should not be allowed to be close to the baby. They do get some IgG protection as it goes from mom to baby during the third trimester, and then also in the colostrum and breast milk. And so they receive this passive immunity for about 3 months to help protect them against bacteria and viruses. Okay, so we have different periods of reactivity as far as the baby's state of alertness. Usually when the baby's first born, they are awake. We're stimulating them, they're crying. But every once in a while you'll have a baby who won't want to cry. And this typically happens when a baby's lungs are wet and you want them to cry. But whether they're crying or they're not, they're awake, they're looking, they're responding to the environment. And this lasts for about an hour. Then they go into a period of sleep that lasts for about 2 hours. And then they have their second period of reactivity at that time. And they wake up, and this is a really good time to feed them. You also want to feed them in the first period of reactivity, if they show interest in feeding. So babies have sort of innate abilities to tune in and tune out to certain things in their environment. Orientation is their ability to focus in on, let's say, a sound or a voice or a touch, where their attention will be drawn to it. But then if it continues on for too long, they stop paying attention to it, and they don't let it influence them, and that's called habituation. All right? Also, it's really good if you have a baby who is self-consoling. That is, for short periods of time, the newborn is able to make themselves happy, whether it's to look at something, whether it's to suck on a part of their body, but they do it by themselves and make themselves happy in some way. Now, babies who are neurologically impaired, whether they're immature, premature babies, or they have some neurologic damage, or they're babies of women who have abused some type of substance, have more of a problem with the habituation and self-consoling. So the nurse has to be prepared to assist with the circumcision before, during, and after it. So usually the circumcision is delayed until 12 to 24 hours after the baby's born. We typically do it on the day of discharge. You don't want to feed the baby for about an hour prior to the procedure so they don't throw up. This is a surgical procedure, so it requires a consent form. And there are 3 different methods: the Gomco, the Plastibell, or the Mogen. They're all a little bit different. The big difference is that the Plastibell does not require Vaseline or a 4x4 to be placed around it. It has a small little plastic device that fits around the penis and falls off within about a week or 2. The nurse needs to restrain the baby on the circ board and make sure that the circ tray and any anesthesia that the physician will use is available. So this is the circ tray. This is the baby turned down, tied down onto it. After the procedure, you want to give comfort measures, pick the baby up, hold the baby, comfort the baby if they're crying. You want to do your best to keep it clean, especially from stool. For the Gomco, you're going to use the Vaseline. It comes out of a tube. You're going to totally enclose the penis with the Vaseline, and you're going to give the parents like 2 or 3 of the Vaseline tubes to take home. Urination should occur within 6 to 8 hours after the procedure. If not, then you have to worry that there's some edema, and that's keeping the baby from urinating. And you want to monitor the bleeding. You know, you can expect a few drops of blood, but not a lot. Usually in a day or so, there's a little yellow crust to form around where the connection of where the foreskin was taken off and the remaining and the penis, and that's normal. It's not pus. It's just a normal thing that happens when you take that foreskin off. And usually signs and symptoms of infection like fever and pus do not occur immediately after the procedure. In general, with males who do not get circumcised, you do not want to retract the foreskin. The foreskin does not retract at all until that baby boy is about 2 years old. The female infant, you're going to wipe from the front to back. There might be some smegma, which is white discharge in between the labial folds, and you could wipe it off, but it's not necessary to take all of it off. Okay, just a few things about cleanliness and giving parents information about it. Babies don't need a tub bath until the cord falls off and that it's well healed. You want to clean around the genitals and around the anus, and make sure that all the meconium gets off, all the stool gets off. Lots of times when they're eating, they get a lot of breast milk and formula around the neck, so you want to clean the neck and the mouth area. After the cord comes off, a daily head-to-toe bath is not necessary. I would probably do it, maybe every other or every 2 days. And tell parents it's okay to touch and clean the soft spot, and to be sure to fold the diapers underneath the umbilicus. Once the baby's old enough to go into the bathtub, you should never ever leave a baby in a tub alone. Feeding schedule, breastfeed, you want to encourage the mother to feed every 2 to 3 hours. For babies who are formula fed, by the time that about within probably 5 days or so, they're going to be taking 3 to 4 ounces every 3 to 4 hours. But again, it depends on the size of the baby. Babies should have 6 to 10 wet diapers per day by day 4 of life. And that's a cutie. All right, thanks for listening, and we will be discussing some of this information again in class with the case studies.